Super excited to have Dr. Harmony Reynolds with us today on our monthly Smart Heart webinar, where we try to provide educational content by world-renowned cardiologists talking about topics of interest for on heart health, heart disease, cardiovascular disease. We've got a fascinating topic. I was telling Dr. Reynolds before we got on that I've known her and been fascinated with the field that which has a particular international key opinion leader status, doing research and been studying for years. But I got introduced to Dr. Reynolds about eight or 9 years ago, and I've been fascinated with this topic ever since. I don't know why it sort of just struck me and hit me as something that has to be incredibly frustrating, and for many years was often ignored. It seems to be getting attention, thanks in part to Dr. Reynolds' colleagues' work in this field. But it's a topic I think that will hit home for a lot of our audience today, who are all Smart Heart members or people that have signed up for our marketing and educational content. So we try to provide these sessions to talk about a particular content that might be of interest, and we'll talk about the mystery of chest pain with no known coronary artery disease, which includes myocardial infarction without obstructive coronary artery disease, and myocardial ischemia without known or visible coronary artery disease. So super excited to have you here, Dr. Reynolds, especially because when you look at your accolades as the director of the Sarah Ross Center for Women's Cardiovascular Research, an international expert on this field that we're talking about today, and your research is really uncovering this mystery for a lot of people, not only diagnosing, but what do cardiologists do about it when they do diagnose it? How do they help people that have been frustrated for years with symptoms just like a heart attack, but they're not actually having a heart attack, or maybe they are. We'll learn today. Maybe they actually are. Maybe there's heart damage being done. So I'm a novice in this field. I've done a little bit of reading and research, particularly your articles, and we'll try to get at the heart of it. So welcome, Dr. Reynolds, to this educational webinar.
Thank you so much for having me. I've enjoyed having science conversations with you dating back maybe 10 years, so I'm looking forward to this one.
Yeah, great. So as I said, Dr. Reynolds is at NYU Langone Health, and has been studying this field for a while, currently has a couple of studies ongoing, and as I just learned, she's applying for another grant for another large multi-center study. So maybe for the audience first, before we kick this off, you can just sort of explain what is MINOCA, what is INOCA, and how do they differ from more commonly known heart conditions?
You bet. Chest pain and heart attack that are cardiac are usually from badly blocked arteries. And when the arteries are badly blocked, they're chock full of cholesterol plaque that has inflammation, cholesterol, grease, And in many patients, and in women more than in men, there is no badly blocked artery, and yet it's still cardiac chest pain, or it's still a heart attack. When it's a heart attack, we call it myocardial infarction with no obstructive coronary arteries, or MINOCA. Sometimes I'll say to patients it's heart attack with open arteries as a shortcut. And then when there's discomfort or related symptoms in the chest that is not a heart attack, but it's still cardiac in origin, and there's no badly blocked artery, we call that ischemia, which means an imbalance in blood flow compared to the heart's needs. That's ischemia, with no obstructive coronary arteries, and now that's called INOCA. And each one has a variety of underlying mechanisms, but there's sort of a basket term. It does get to me a little bit that we're defining this type of heart disease, which is not solely a women's heart disease, but is predominantly seen in women. We name it by what it isn't. And as a feminist, I always feel like, hey, wait a second, don't tell me I'm not a man. But that's just the way, this is an evolution of a field. We know that most chest pain and heart attack is from arteries, and this isn't. So it's MINOCA, INOCA.
And the prevalence, at least what people think, is the prevalence in and the gender differences for MINOCA and INOCA. Can you explain what you found in your research that helps maybe uncover why that might be, or even if it's true?
There's definitely a difference in the prevalence. So if you look at heart attack patients, women are 3 times as likely as men when they have heart attack to have no badly blocked artery. And that's particularly noticeable in the people who are not the ones who have an ST elevation myocardial infarction. Their ECG, including the one they might get on Smart Heart, does not show something that means we need to rush them in to open the cath lab. But that's 3 times more common among women than men once they have heart attack. And then when it comes to the stable patients with chest pain, INOCA, not having heart attack, when people get to the cath lab to see how badly blocked their arteries are, a surprising proportion of patients have no badly blocked artery. It can be half. And INOCA patients are 2/3 female. So that becomes so common that there are millions of patients in the United States affected by INOCA. Probably it's an estimated 3 to 4 million, and 2/3 of those are women. Now, why? That is a trickier question. We can just count the numbers, but the why is a big thing that I am very interested in trying to research. And these are unanswered questions. We know that women develop atherosclerosis, that cholesterol plaque buildup, on average 10 years later than men. And no matter how you slice it, if you take a group of patients, even where everybody's got plaque buildup, and then you see how much there is, women typically have less. On average, women always have less. Even women who go to bypass surgery have less disease than the men who go to bypass surgery. So there's something about women getting less atherosclerosis. Women are still at huge risk from heart disease and may have very disabling symptoms, but tend to have less plaque buildup. And then it becomes a question of why women are still having events if they've got less plaque. And that is a really interesting research question that people are attacking from different angles. My colleague Jeffrey Berger, who's got the office right behind my screen, he's looking at it in terms of blood clotting. Do women have different blood clotting than men? Different blood clotting features, especially with platelets, the cells that cause our blood to clot. And it looks like women do have different clotting. That kind of makes sense, right? Because women are menstruating every month for all those years. So that might be one reason. The plaque buildup, the character of the plaque buildup may be a reason. The ability of the arteries to respond to stress by increasing their size and allowing more blood flow or narrowing when we need less, that may be impaired differently in women. So a lot of different avenues of investigation.
So if we could stay in a cath lab just for a second, where you started that response. I came from early in my career, coronary stents, drug-eluting stents, and there was this sort of tongue-in-cheek, what we should just stent the first 40 millimeters of every coronary artery and we could prevent all deaths from heart attacks, like do that prophylactically. But from what I've read, it's obviously there are many more arteries than just the 3 main arteries in the heart, hence this topic. And so I'm just curious, when there's no known coronary artery disease, and first, how is the heart attack diagnosed if you don't see any plaque? And then is the damage sort of is it the same? Are they as big areas in the heart that end up sort of dying and having the infarction? How do you diagnose a heart attack if there's no known coronary artery disease? And then, is it as bad to have a heart attack when you have no known coronary artery disease versus having plaque that's visible?
These are such great questions. So it's interesting that the definition of heart attack never has in it that an artery has to be badly blocked. The heart attack definition is about having biochemical evidence in the bloodstream that there's been heart damage, and the measurement that we use now is troponin. This is the thing that I always tell my patients: if you've got chest pain, you go to an emergency room, ask them what your troponin is, because you need to know if you're having heart attack. It's got to be that plus something else that shows it's coming from the heart, whether it's symptoms or EKG changes, echo finding, but there's got to be something else. But you don't have to have badly blocked arteries to have compromise of your heart muscle from blood flow. At least you don't have to have badly blocked arteries on the test we do that shows us the largest arteries. But as you said, the arteries they have smaller and smaller branches. So I'll usually say to patients, the arteries are like trees, and just like trees, there are the big trunks, and then there are smaller and smaller branches. And just like in trees, most of the action is in the small ones where the leaves are in the trees. And those are the smaller arteries that regulate blood flow. They're primarily responsible for regulating blood flow, and it's not really the large pipes day to day that are most responsible. So all that to say, you can definitely have a heart attack with no badly blocked artery, and there's at some point a problem with flow, and I can run down all the possible reasons that happens. But you asked, is it just as bad? And it depends. You can have just as large a heart attack with no obstructive coronary disease, because an artery can become very badly blocked, a large artery, from other things, from artery spasm, et cetera. And then it's really all about how long that heart muscle has been compromised. But it's also true that on average, the heart attacks with open arteries tend to be smaller. And the prognosis tends to be better, probably because they're smaller.
That's fascinating. And in the same sort of, staying on the same topic of MI, when someone is diagnosed with MINOCA, are they at higher risk for MINOCA? Like, is that?
You would think, but there's not as much overlap as I would have expected. The common mechanism to those two things is artery spasm. And the way that I usually describe that is that all the arteries have a muscle lining. And if that muscle goes into a cramp, just like a leg muscle, well, here it's in an artery, so it will temporarily narrow or close that artery, and it'll limit blood flow until that cramp releases. That is a mechanism of both INOCA and MINOCA. So there are definitely some people who have both, but not as many as I would have guessed.
Interesting. So if you have a patient who has a heart attack with no known obstructive coronary artery disease, is it a similar risk for a second event from a MINOCA, where people that have obstructive coronary artery disease or plaques and have had a heart attack are at high risk for another one? Do people that have already had a heart attack and been diagnosed with MINOCA, are they similar risk for another heart attack?
It's lower risk, but it's certainly much worse than never having a heart attack in the first place.
Got it. So I'm sure this path has to be super frustrating for a lot of women and men, mostly women, as you pointed out to our audience. That you know something's wrong, something's happening. Not everybody is an expert in this field like you. There's a lot of physicians out in rural areas that aren't attuned to the data. Maybe they're just cath jockeys, as they say, and treating patients that have obstructive visible disease or not, and then they don't. If they have chest pain and it's inexplicable because there's no coronary artery disease, you send this patient who's having this chest pain and they know that there's something wrong down a series of diagnostic tests like stress tests and maybe CTs, etc. But before we get into the diagnostic process, what are the symptoms that might lead a physician to suspect, or even suspect, or maybe things that you can shed light onto our audience where they might actually have INOCA or be at risk for MINOCA?
It's so true what you said about the frustration, because it's not just people in rural areas. I mean, it's hard to keep up with all the medical literature, and I get that. But there are loads of physicians, whether emergency department physicians, internists, or sometimes even cardiologists, who don't realize that you can have a heart attack with open arteries. And so they will sometimes turn around to that patient and say, good news, it wasn't a heart attack, when it was. And that's a great frustration. Sometimes it isn't a heart attack. And we can get into diagnostics later, but there's one particular test, a cardiac MRI, that's super important, because you do have to turn around and say, am I sure this was heart attack? And an MRI will occasionally tell you it wasn't. But without that, most of the time, if it looks like a heart attack, it is a heart attack, even if the arteries are open. but the symptoms are identical. The EKG changes can be identical. The look on an echocardiogram can be identical. There's really no substitute for just doing an angiogram and seeing if the arteries are badly blocked.
And if they're not, and they're experiencing similar symptoms to what someone that does have blocked arteries, then you would send them for an MRI.
If it's heart attack with open arteries, yes, you can also do more imaging right
Or
at
even
that
if it's
moment.
not, if it's just ischemia, if they're just having chest pain and not, would you send them for an MI then? Or an
The
MRI?
pathway is a little bit different. In both, during an angiogram, during a cardiac catheterization, there are more measurements that can be taken in order to see exactly what's going on. And I'm a big believer that if a patient comes in for an invasive procedure because we need to make the right diagnosis, that person should exit, if at all possible, with the diagnosis. And that means extra testing. That takes a bit more time and takes a bit more expertise. But my goal for the long term for the United States is that everybody who comes in for a diagnostic angiogram should leave with a full diagnosis. And then afterward, there are other tests that may be useful. For the heart attack patients, MRI is really helpful because it will show us if there's an area of damage, you can see it. And then if that damage may clearly be blood vessel related. And the way that it works, by the way, is that the MRI shows you the heart and the arteries ride on top of the outside of the heart muscle. So that inner layer of the heart, if you imagine a donut, right, it's the inside of the donut, but that's farthest away from the blood supply. And if it's a blood vessel problem, then the damage will be on the inside first because it's most vulnerable. The blood is the blood supply. And you'll see also, we know where those coronary arteries go. So damage would be in the territory of one coronary artery. So you can put that together and figure out, look at it and say, oh yeah, that's a blood vessel problem. But in inflammatory problems, for example, like myocarditis, a viral illness that affects the heart, then that has nothing, it doesn't look like a blood flow problem. It might be sort of splotchy. It's not going to respect the territory of one artery. It'll be in the territory, let's say, of all the arteries. So you can just look at it and see the way it lights up, and it's clearly very different. So MRI is super useful.
Yeah, I think that's really important to our audience. It's really fascinating that the telehealth visits that our group, Heart Nexus, conducts with some of our users is exactly this, where people know they just know that something's wrong. They have chest pain, inexplicable chest pain. They've been ignored and disregarded. A lot of them tend to be women. We do have men that we just recently had a customer who just knew something was wrong, and it sounds like if you keep pressing and pushing on this, like maybe you can request an MRI if it's inexplicable and they haven't done that yet, to see if maybe there is some damage. Will the ischemia show? Sorry, did you say the ischemic areas will show up on an MRI?
MRI is not my favorite test for that. If we're looking for small artery disease, then my favorite tests are invasive management at the same sitting in the cath lab, or a different one if we need it. Or there's a type of nuclear stress test called PET that can give us exact amounts of blood flow and can be very reliable for looking at whether there's small artery disease.
So I think the point is, have you tried every test to find out whether there's actually something wrong with my heart?
Yeah.
That's excellent. So once someone has been diagnosed with myocardial infarction, where there's no non-obstructive disease, or maybe ischemic non-obstructive coronary artery disease, what are the treatment options for those patients at this point?
I really feel strongly that the treatment has to follow the diagnosis, because it's a variety of diagnoses. For heart attack with open arteries, could be that there's plaque buildup, and it's the same old story of the plaques become vulnerable. My colleague says it's like a pimple that pops. It's got a bunch of greasy, or I say it's like an egg that cracks. There's a bunch of gooey stuff inside. It breaks, it flows into the vessel, and then the flowing blood will clot on that, block that artery. That's a heart attack. Now you can start with a large plaque, and that is more the typical stuff. But you can start with a small plaque and get a very similar phenomenon. So it could be that there's plaque there. The plaque is the problem, plaque plus blood clotting, and it just happens to be a smaller plaque that people weren't thinking about in the same way. Could be that it's artery spasm, which I think I talked about. Sometimes it's just a blood clot. People have a blood clotting tendency, or maybe they're on hormones. There might be just a reason for blood clotting, and that blood clot can travel and just block off the artery. And rarely there's a thing called coronary dissection, which usually we recognize on an angiogram, but it can be missed, or once in a while it'll show up as a MINOCA. And that's a bruise inside the blood vessel wall that can expand and temporarily close the artery. All those things are very different, and they're treated differently. If we understand that it's plaque buildup and blood clotting related, then we use our typical cholesterol lowering and antiplatelet drugs. If we think it's artery spasm, then the main drugs are in the calcium channel blocker and nitrate family. If we think it's a blood clot, well, we've got to figure out where that blood clot is coming from, and we're using anti-clotting drugs. And if it's that dissection thing, well, we're not sure how to treat that, but it's not with the cholesterol lowering and the anti-blood clotting things. So it really does matter what you found. And sometimes we're left saying we can't be sure, and we will give a group of, let's say, 5 or 6 medicines. People don't always love that, which brings me back to the idea that I like to know exactly what I'm treating if I can. Sometimes we find out, especially with an MRI, that it wasn't heart attack at all. Now we don't need those 5 or 6 medicines, which is fantastic. When it comes to the stable chest pain, the main mechanisms there are artery spasm and small artery disease. And they too are treated a little differently. Like I said, the calcium channel blockers and nitrates for spasm. And for small artery disease, often medications in the ACE inhibitor or angiotensin receptor blocker family or beta blockers, those tend to be a bit more effective. So I really like having dedicated testing, but sometimes I don't have dedicated testing. You know, I'll say to people, I can manage you 1 of 3 ways. I can get the comprehensive invasive testing, and I like that the best intellectually because I feel like I know the best what path to follow. Or we get non-invasive testing and I get partial information. Or I can do none of these tests and we can try and see how you're doing and try and figure it out that way. So I think those are all the approaches.
Got it. I'm messing with my air conditioner over here because it's the last weekend of summer and it's warm here in Boston. I'm seeing your plant swaying with the AC, and my air decided not to work right now for me. I'm on the 3rd floor of my house. That's why I keep messing with something over here. So can you just talk a little bit about your recent research and the findings related to MINOCA and INOCA, and maybe some things that our audience might be sort of looking forward to based on the outcomes of some of the studies you published?
Sure, I get very excited about my research. For the MINOCA patients, we published not so long ago that in a group of women, we can find the cause using multiple types of imaging in 85% of the women. And that 2/3 of the time we find some evidence that that heart attack looking thing really was a heart attack. About 1 in 5 will have some inflammatory or other problem that is not heart attack, but only 15% of the time did we have to turn around and say, hey, we're still not sure. So I found that very gratifying. But we're now in the stage of enrolling more patients and especially enrolling men. Because how are we going to understand why this shows up more in women if we don't test men too? So we're trying to get to the root of what's different between women and men and see if we can explain why more women get MINOCA. At the same time, though, we're taking blood from patients and banking it so we can figure out what blood biomarkers might be associated with the various causes. Because after all, we're doing expensive and sometimes invasive testing as part of this research protocol. And I would like to be able to tailor that testing in the future to specific patient groups. But at some level, you just need more patients and also theoretically more biomarkers in order to be able to pick out who has what problem and what they might benefit from. So that is my main research program, and that's the funding that we have for the Soder Center for Women's Cardiovascular Research. In INOCA, we published recently through an international collaboration, the CHOW ischemia study, that there's a lot of variability over time in how people feel and even what their stress tests show. All the patients in CHOW who had INOCA, they had stable symptoms, mostly chest pain, and had a very abnormal stress test. When they entered, they all had very abnormal stress tests because that's how we chose them. We chose people who looked pretty sick based on their stress tests. And in a year, a half of them were normal, which was fantastic news. And certainly a certain number were not normal still, but the symptoms were also quite changeable. So we had a number of people who felt better. We had some people who felt worse and some people who felt the same. But interestingly to me, the stress tests and the symptoms didn't always track together. And that says a lot about how people change their lifestyle in order to get get by with their symptoms. Sometimes there are people who feel some kind of symptom and they're concerned about it, so they'll do a lot less. That's a lesson to me as a physician, that I want to try and push people to exercise a bit more, make sure I'm treating their symptoms so they can do the things they want to do. But also there's just a certain amount of ebb and flow that now is a reason to do more research and figure out how can we pick out the people who are getting better and why are they getting better, because I want everybody to feel better. We're also doing a study trying to figure out how we can make the diagnosis in a much more generalizable way, because I am a big fan of the invasive testing because I want answers, but I'd sure like non-invasive testing. So I want to thank you for supporting our study to figure out if EKG changes while people are feeling symptoms at home can be a predictor of whether invasive testing is going to be normal or not. It would be really helpful not to need to do this invasive testing in everyone and to be able to figure out the diagnosis at home and all across the country, even if you don't live near a specialized center. So that I'm particularly excited about. And then the last study that I've launched recently is actually home cardiac rehabilitation for patients with MINOCA, because we know that exercise makes people feel better. But dedicated in-person cardiac rehab is really time-consuming, and not everybody lives near a center. Plus, we know women are less likely to go to cardiac rehab, and there are various reasons for that. I'm not sure why exactly, sort of a catch-all of reasons. But certainly home exercise is something that people have been asking for, and we want to see if it works.
I was listening to a podcast before I got on with you earlier, and one of the cardiologists was talking about, I wasn't sure if it was a published study, but talking about the benefits of HIIT, high intensity interval training for people with an MINOCA or diagnosed MI. Is that a thing? High intensity.
That's part of what we're studying. So you have to send me that podcast.
You're studying that, you said?
Yeah, that's part of the rehab program, is when to introduce high intensity interval training.
Oh, okay. Fascinating. I know not everybody can do high intensity interval training, but certainly if there's a benefit to try to mix it in, that would be.
Well, not everybody can, it's true, but I'm always asking people to do interval. And I think the key is to understand that it's what's hard for you. So what's hard for me, I sit a lot in this job. So I'm not as fit as I would like to be some of the time. When I get some vacation, all of a sudden I start to feel much stronger and fitter, and I lose weight on vacation because I get up out of my chair. But in high intensity intervals is doing a minute of what feels hard to you. Not so hard that you can't finish that minute, but hard enough that you're watching the clock. And I feel that most people can do that. It's just that what's high intensity for you might be a lot more than what's high intensity for me, might be a lot more than what's high intensity for one of my patients who's got severe heart disease.
Are you familiar with Tabata?
I've heard of it, but I don't really know how it works.
Yeah, I'm a big fan of it. It's just 20 seconds on, 10 seconds off for 4 minutes. It's a 4-minute workout. It's actually technically, you're only doing 40 seconds times 4, you're doing 160 seconds worth of work in 4 minutes. But you can get a heck of a workout in 4 minutes with just going all out for 20 seconds, resting for 10 seconds, all out for 20 seconds. And Mr. Tabata invented it, and there's all kinds of there's an app with a Tabata timer. I'm a huge fan when you don't have a lot of time to mix in some Tabata.
Does it matter what exercise you do, or you just do whatever you feel like?
It could be the rower, it could be the bike, could be planks, 20-second plank, 10 seconds off, 20-second plank. You can do it on your elbows, you can do it on your knees, but I'll mix in, just body weight squats, Tabata. So you don't have to do them all at the same time. You could also do 20 seconds Tabata squats, 10-second rest. 20 seconds of push-ups, 10-second rest, 20 seconds of, so the full 4 minutes, you're just doing 20 seconds of work, of strenuous work, and 10 seconds rest for 4 minutes. I do it all the time, even though you can't tell. People are supposed to be in better shape after the summer. I'm certainly not.
All right, I'm going to get a timer. Thank you.
Yeah, check it out. I think it's really good. Any underlying mechanisms that help predict risk here for these two types of conditions that you've been able to tease out from either your own work or other people's research?
Well, I'm not sure exactly what you mean. I mean, there are things like smoking, colossally high cholesterol that tend to help us build up plaque. But the non-obstructive patients have those things too. They just don't have quite as much of it in general on a population level. But I'm not sure if that's what you mean.
It is actually. Is it the same risk factors for heart disease that contribute to MINOCA, INOCA?
Yeah, 75% of the patients with heart attack with open arteries with MINOCA have at least one of the traditional risk factors. So they're probably fairly similar. And I think that's also because a lot of MINOCA turns out to be plaque related, like I was describing. It's just a smaller plaque. And maybe that blood clot is even smaller, and that blood clot can travel down the vessel like something going downstream in a river, and then it just gets stuck. So that's the area that causes the heart attack. But everybody's looking at the big artery when the problem's really in a small artery, and it was caused by a big artery and often a piece of blood clot breaking off. So a lot of it is plaque related, and I think that's why so many of the risk factors are the same. And in fact, you mentioned recurrent heart attack, and when people come back after a MINOCA with another heart attack, it's not that common. It's 7% at 4 years. But, you know, we'd love it to be 0. Those second heart attacks, about half of them, the plaque has progressed to a level that we consider important on an angiogram. And for half, the arteries are open, which just shows, again, that the first event was often due to plaque too.
I don't know if we talked about CT. If we did, I apologize, but I spent 15 years in invasive sort of technologies for treating disease, and for the last 10, more on the diagnostic side. I spent a couple of years at an AI company trying to characterize plaque, trained on histology slices, looking at the different material within the artery wall that might sort of predict events. So there's some really exciting stuff happening in the CT world. Is the CT exam helpful here for this type of condition, these conditions?
Great question. I mean, it is and it isn't. In the heart attack patients, the invasive angiogram, it shows us where the blood is flowing. It doesn't show us the wall. And we can be left uncertain whether there's any plaque at all or none. And it's really helpful then to know if somebody needs cholesterol lowering, because if there's any plaque and there's been a heart attack, we're usually going to treat that cholesterol. But you can tell at the level of resolution in CT today, you can't tell if that plaque was an active plaque that was the cause, a culprit lesion for a heart attack, or if it's sort of a bystander. For that, you need imaging from inside the artery that I know you're very familiar with. For the INOCA patients, the CT is, again, just there to tell us if there's any atherosclerosis, and there usually is. About 75% of the time, you're going to see some little bit of plaque there. Is that plaque part of the reason for chest pain? You know, our studies would suggest maybe not, in that the amount of chest discomfort and the amount of plaque don't seem to track. The amount of abnormality on a stress test and the amount of plaque also don't seem to track when there's no 50% or greater narrowing symptoms.
When we first started talking about your study that where you're utilizing Smart Heart, I remember you mentioning that, if I remember correctly, you said women that have this diagnosis tend to come to the ER 4 or 5 times a year, like every few months they're in the ER, they're having chest pain, they don't know if it's a heart attack. And so maybe there's a promise here that we can maybe allay some of those fears that it's not a heart attack if there are EKG changes, which I know we aren't certain of yet. But
Right.
so I'm curious, you know, for our audience, if people go to the ER and you know they suspect that they're having a heart attack, maybe you can talk about the symptoms of MINOCA for a second, just to refresh everybody's memory. But if you go to the ER and you're having typical symptoms of a heart attack, which are very similar to MI from non-obstructive coronary artery disease, and there's no troponin bump, there's no EKG changes, is it still possible that you have MINOCA or INOCA? And then if you go and you have chest pain and you've been turned away, they've done a workup, they do the EKG, they do the troponin, what do you sort of do then? You don't have the diagnosis yet. Let's say you don't have the diagnosis yet. but you have this inexplicable chest pain. What's the first thing someone should do if they've been turned away from the ER and tell them it's fine, it's just anxiety, there's nothing to worry about? But they know in their heart of hearts, it is their heart. It's not the anxiety.
I have so many patients who have been told that they're anxious. And I saw two women who had heart attack in their 20s just yesterday, both of whom got to the emergency room and were told, don't worry, you're fine. You know, you're having an anxiety attack. You seem like an anxious person. And those women were both having heart attacks. It wasn't until their troponin came back that people figured it out. And you mentioned the EKG. In one of them, the EKG was definitely different than it was before, and somebody needed to put a really sharp eye on that EKG. But of course, she was initially told her EKG. So I hear that story over and over again. And it's just sort of some kind of narrative that we have about people being anxious, women being anxious in particular. So what do you do about it? I think what I tell all of my women to do is I warn them about heart attack warning signs, which I'll go through in a second. And I say, and if you have that for 10 or 15 minutes, you should be going to the emergency room, call 911, because that's how people get the most attention. And anyway, it's an important thing. And come in and say, I think I'm having a heart attack. And people don't always want to vocalize that because it's frightening. But don't worry, people will be very quick to tell you if they can show that there's no heart attack. But if they tell you there's no heart attack, you kind of have to say, how do you know? Because I think that is very useful in order to make sure that nothing else is wrong. And then afterward, if you get the green light and you're released from the emergency room, great. I would seek out a cardiologist and ask, could this be my heart? And again, how do you know it isn't? If it isn't, because people need dedicated testing. Heart attack symptoms or cardiac chest discomfort, it's mostly going to be in the chest, but it might not be painful. Heart attack does not always feel like it looks in the movies. It might just be uncomfortable or hard to describe. And it's usually in the chest, but it might not be exactly in the chest. It could be in the jaw, neck, shoulders, either arm, back, upper stomach, or the chest. Some people get shortness of breath or just a feeling that their breathing is labored, nausea or vomiting, sweating, dizziness. You can have only those things, or you can have none of those things. And that might come with or without chest discomfort. So there's a lot of different things that can appear as heart symptoms. People say that women have different heart symptoms. Probably not true, actually. In general, women have more symptoms. So for a male and a female heart attack patient, the woman's more likely to report maybe not only chest discomfort, but also sweating. Or if the man has chest discomfort and sweating, the woman's also got shortness of breath. Women just tend to have more symptoms or report more symptoms if they're talking about it. But the general types of symptoms are the same, just as they're the same if the heart attack is from open or closed arteries. And it can get confusing. So what I usually say to patients about that is, let's say you eat a sausage and pepper hero. And of course, I can't even stop myself. I immediately say, you should not be eating the sausage and pepper hero. But if you did, and it always gives you heartburn, then the next time you feel that, you're not going to think it's a heart attack just because we had this conversation. You know what that is. But if you felt it and you hadn't eaten the hero, and you had no reason for it, or you felt something that you didn't quite expect, that's what I want you to go to the hospital for if it's lasting 10 minutes or more.
I've heard not from women that have been diagnosed with this, but that dismissive, it's all in your head story from a few different women, and then a couple of women in that group have said that the doctor gave them one of the patches, like a Holter monitor patch, to wear for a couple of weeks. Came back clean and normal, and then that's when the doctor's like, this is all in your head. It must be all in your head. It's fine. We've done all your tests. Will those patches help at all in this scenario with someone who has MINOCA or
for chest pain?
As far as diagnosis?
Yeah. No, I've been able to find something that I thought was a cause of chest pain maybe once or twice on that kind of monitor. No, that would generally not be useful. I'm not sure if what those doctors was trying to find was a heart rhythm problem. Heart rhythm problems are easily diagnosed that way, but you have to catch it in the moment when you're wearing the thing. Otherwise, you're not going to find anything.
Yeah, makes sense. So I'm going to open it up to there's a couple of questions here because we're coming up on time. we're going to wrap up here in about 5 minutes. We did a webinar about stress and the effects of stress and mental health on cardiovascular disease. I know we just talked about anxiety and it being on your head, but not so much as a risk factor. So is stress and mental health, and if you've been, if you actually have been diagnosed with an anxiety disorder of some sort, is that a risk factor? Does that contribute to the progression of MINOCA or a risk factor for MINOCA?
I think you're bringing out a few different things, but let me try and address. So I can think of a few different answers to that. One is stress is absolutely a risk factor for heart disease, and it's something that we all need to work to manage. There are effects of stress on the mind, but also effects on the body, and that is a real thing. Stress also triggers all kinds of heart attack, whether it's the traditional heart attack with blocked arteries or heart attack with open arteries. Stress is definitely a trigger. So is physical stress, right? Everybody knows about the idea of somebody shoveling snow and getting a heart attack from the extreme exertion. I mean, if you think about having extreme mental or emotional exertion, you can imagine that that would also put a strain on your heart. So that connection is real. It is also true that people who get panic attacks, once it's sorted out that it's panic, because the first time you can never be sure, and a lot of people go to the emergency room, which is the right thing to do, right? You need to get checked out. And then once it's clearly a panic attack and not heart attack, people wonder, am I now going to stress myself into a heart attack by making myself anxious and feeling my heart pounding? That doesn't happen. So that's one less thing to worry about, because if you've been carefully evaluated for heart disease, that's not what you have. You have panic attacks. You can just get through that. Panic attack is generally going to subside in a few minutes, and you're not going to give yourself a heart attack from worrying. But you shouldn't jump to the conclusion that it's panic either. Does that answer your question?
It does. It does. It
Okay.
does. It answers my question. I don't know if it opens up more questions for the audience or not.
Sorry, there's one other research study that we did might be of interest. And we thought, as many people do, that if heart attack with open arteries, well, if there's less plaque buildup, maybe stress is a bigger contributor to that type of heart attack. And it turns out it isn't. It's the opposite. Stress is a bigger contributor to plaque buildup type of heart attack, not the open artery heart attack. Sorry, go back to you.
Oh, that's helpful. That's helpful. There's a question about whether or not there's a link between, if you have a family history of heart disease, family history of heart attack, that you would, have obstructive disease, and is there a generational link here with MINOCA and INOCA? Is it hereditary? Does it pass down from?
It's not hereditary in the way that sickle cell anemia is, where, if one of your parents is affected, you're very likely to be affected. It's not a single gene type of a thing. But when families have a history of heart disease, some of the people will have open artery heart attacks, some will have closed artery heart attacks. It's sort of part of the same thing.
Got it. Then we're coming up on time. I have one more question. If the symptoms are so varied, and maybe you don't have a bunch of risk factors, and people can experience a heart attack so many different ways, there's so many varieties of symptoms, then how do you know if you're at home and you're having whether it's obstructive or non-obstructive? And I know we're talking about obstructive or non-obstructive pulmonary artery disease. How do you know when to go to the ER? Like if you're nauseous, or you're sweating, or you're fatigued, but you're not having chest pain, you're not having pain down the arm, which can be also symptoms, I know, of the topic we're talking about here. But if you're sitting at home and you're not having that typical crushing chest pain, that is the telltale movie signs of a heart attack, how do you know when to go to the doctor or go to the hospital?
This is why I try to say this thing about the sausage and pepper hero, because I know once I list a laundry list of what feels like a dozen symptoms, it feels like everybody's had one of those things in the last week. But if you had it for more than 10 or 15 minutes is a long time to feel off.
Okay.
And if something feels wrong to you, you know, let's say you start throwing up and you just ate some bad chicken salad, you know you did that, or everybody else in the family is sick, you have a context for that. But if somebody starts to get severe nausea and start vomiting and there's no reason for that, I would go to the hospital if that's not going away. If you're at all concerned that that might be heart related, and certainly if it comes with any chest discomfort, because I find that people sometimes don't think of the chest discomfort as their primary thing. But if you keep talking, they'll say, well, yeah, there was something here. And that is what we're talking about with chest pain. It really does not have to be all that dramatic. I hope that's helpful.
That is very helpful. Actually, we've had a number of physicians on. We asked that question and haven't gotten that one before. Like, you know, if it's sort of out of the blue and inexplicable, there's no correlation to the sausage hero that you just ate off the street corner in Manhattan. Get yourself to the ER. So we're going to wrap up. I just want to, if you could just share a couple of final thoughts, maybe for the audience, who, you know, we tend to get people that sign up for our marketing that have a family history. They have a family member who has had an event. They have a child that maybe, you know, has a pacemaker or a defibrillator. Right, there's some relation here to the people that sign up for our educational webinars, where there's an interest and an intrigue. And so, as it relates to the field that you study, I don't know if there's anything you want to share, any last words of wisdom for the group.
Well, I think that when I worry about heart disease, I find it helpful to get up and walk. And I think that getting something like a Smart Heart, and you know you're taking care of yourself, you're going to the doctor. I feel like if you're part of this group, you're somebody who's clued into health, which is wonderful and is a great start. Use that knowledge, share that knowledge with others. But if it starts to really preoccupy you, I find it's helpful to focus on something that you can do for yourself that's healthy. Go find a healthy recipe, cook yourself some healthy dinner, get up and walk. And just having that knowledge and sharing it means a lot. So I think it's wonderful that you have these webinars. Yeah,
thank you so much for coming on. It's been a true pleasure. I learned a lot. I hope our audience learned a lot. We're looking forward to your research and helping the field progress. I know you've helped a lot of people so far, and I don't know if the prevalence is growing or if it's just because physicians are becoming more aware and diagnosing it now because of you and your colleagues' research. Hopefully it's the latter, not the former, that it's sort of growing trend in heart disease. But it was enlightening. I learned a lot today. I hope our audience learned a lot, and have a great rest of the summer. Last weekend of the summer. Happy Friday 13th. Hopefully it's not a bad luck day for you, and we'll see you soon. Thanks so much.
Thank you so much.
Yeah, take care.